Good afternoon, ladies and gentlemen. My talk today will be on Stevens-Johnson syndrome and toxic epidermal necrolysis. Is this the way? Both are life-threatening skin diseases with a mortality rate reaching 30%. Only prompt recognition and diagnosis, withdrawal of the culpable drug, and referral to an intensive care or burn care unit can provide any hope of improving the prognosis and saving the patient's life. According to a consensus classification established by a group of contemporary experts, categorization of these diseases is determined essentially by the percentage of skin detachment and by the semiology of the typical individual target-like or erythema multiforme-like lesions. Since the involved area of detachment is defined as such at the worst stage of the disease, it cannot always be delineated when the patients are first seen by the clinician. Consequently, the most and very often the only reliable means of classifying the cases is by observing the pattern of the individual lesion. According to the consensus classification, the clinical pattern of erythema multiforme-like lesions appears as one of four configurations. Typical target, you see here the definition. Raised atypical targets, flat atypical targets, and macules with or without blisters. Where's the pointer? Okay. Okay. So the erythema multiforme group, you see it here, consists of typical targets and raised atypical targets. Stevens-Johnson toxic epidermal necrolysis group consists of flat atypical targets and macules with or without blisters. The erythema multiforme group is often a reaction of infectious diseases, most notably herpes and mycoplasma infection, while Stevens-Johnson toxic epidermal necrolysis is often attributed to the ingestion of medication. The erythema multiforme group is a benign and recurrent disease, whereas Stevens-Johnson toxic epidermal necrolysis group is a life-threatening skin emergency. So we have to be able to differentiate between these two diseases. And this is actually the aim of my talk. In addition to the presenting with lesions whose characteristics are compatible with the consensus classification, we have noticed that patients of the Stevens-Johnson toxic epidermal necrolysis group sometimes also have typical targets that are flat and are missing the palpable ring around the center. These flat typical target lesions are short-lived and usually coalesce, or they turn into flat atypical targets. We therefore suggest adding an additional type of lesion to the nomenclature, namely flat typical targets, and call the original typical targets raised typical targets. This new classification will contain 5 types of lesion. And look how it's easy now. Raised typical targets, flat typical targets, raised atypical target, flat atypical targets, macules with or without blisters. The erythema multiforme group would consist of raised typical target and raised atypical target, similar to the original definition. And the Stevens-Johnson toxic epidermal necrolysis group would consist of flat typical targets, flat atypical targets, and macules with or without blisters. Now, why a new classification? We believe that our proposed one incorporates the entire range of these lesions and that it is more compact and easier to understand and easier to remember, even though it contains an additional type of lesion. How can extending a classification make it more compact? In our proposed modified classification, all the lesions that are found in erythema multiforme group are raised, whereas all the lesions that characterize the Stevens-Johnson toxic epidermal necrolysis group are flat. And so, the take-home message: if a patient has raised lesions, typical or atypical targets, we lean towards a diagnosis of post-infectious erythema multiforme, again, recurrent disease and not an emergency. The presentation of flat lesions, typical or atypical targets or macules with or without blisters, should immediately alert the possible diagnosis of drug-induced Stevens-Johnson and toxic epidermal necrolysis, and these patients go directly to the burn care unit. Treatment consists of intravenous fluid therapy, monitoring, culturing, analgesia and sedation, prevention of stress ulcers and thrombosis, meticulous eye care, a high-protein caloric diet, respiratory physiotherapy, and more. I will not go into detail about therapy. I prefer to focus instead on several controversial issues, starting with topical treatment. The aim of local treatment methods used for toxic epidermal necrolysis are to minimize heat and fluid loss from the wound, prevent wound infection, reduce pain, and provide a moist, clean wound environment in order to promote reepithelialization. Burn centers commonly favor early debridement of all non-viable tissue, followed by the application of temporary skin replacement. The biologic or biosynthetic dressings are designed to remain intact over the denuded surfaces, generally 1 to 2 weeks, and only the outer protective or antimicrobial dressings are changed daily. In contrast, most dermatologists believe that extensive and aggressive debridement of necrotic epidermis is not recommended in toxic epidermal necrolysis because, unlike the case in burns, the necrotic epidermis sheets are very superficial, and so they do not represent an obstacle to reepithelialization and might even accelerate the proliferation of stem cells due to inflammatory cytokines. We recommend leaving the involved detachable epidermis in place and using dressings only to protect it. Dressings may be gauze with petrolatum, silver nitrate, hydrogels, or others. A much more controversial issue in the treatment of toxic epidermal necrolysis is the use of disease-modifying drugs. Corticosteroids have historically been the mainstay therapy for toxic epidermal necrolysis and Stevens-Johnson syndrome in most of the dermatological centers. This approach was followed by a complete turnabout at the early 80s, and one cannot help but wonder if this had not been influenced by non-dermatologists at burn centers to which the management of these patients had been shifted. In the first international symposium in Créteil, France, that took place in 1985, where most of the world's authorities of this disease were present, it was the unanimous conclusion of the group that corticosteroids are of no particular value in the management of toxic epidermal necrolysis, and they condemned its use once the disease has progressed to large body surface areas, meaning more than 20%. We have recently been feeling the winds of change, with the waning of the negativity towards steroids and the allegedly harmful effect. Several authors have concluded that the general negative opinion of corticosteroids was probably generated because they had been given too late, in too low a dose, and for too long a period during the disease process. As a result, we are now witnessing a new trend of treating toxic epidermal necrolysis, Stevens-Johnson syndrome patients, with high-dose pulse therapy. Again, this is the message to take home. As recommended by other authors, we endorse the use of 100 milligram per day dexamethasone or 700 milligram prednisolone IV over short periods, meaning 3 consecutive days, a protocol which has shown favorable results. Support for the use of corticosteroids has recently come from the publication on a cohort of 281 patients with Stevens-Johnson and toxic epidermal necrolysis who were enrolled in the Euroscar study. Of course, Jean-Claude Rougeau was one of the authors. The conclusion of the authors, some of them known opponents to steroids for these conditions, was that their results do not support the prior opinion of many experts that corticosteroids were detrimental in the treatment of patients with toxic epidermal necrolysis. They added that there is a trend for a possible benefit in the use of corticosteroids that can be of further clinical interest. I will not go into detail of IVIG and just thank you for your attention.